This Assalamu alaikum. Welcome everyone on board, and thanks a lot for joining us. Um it's been a pleasure for me that Dr. Luqman Osman, who has been my academic impulse, and I'm following him since at least if I'm not wrong, it's 16 years now,
It was 16 years,
and
yes.
and
Pretty long time.
so Dr. Luqman, you can just introduce yourself, and then we will.
Yeah.
In the meantime, we will have some more people.
Yeah, but I think like
Yes,
very kind
one
words
more
first.
one
Yeah.
more
I
minute.
think
In the
still,
mean,
yeah, one more minute and then we can start. No problem. We will start right at 8:30.
so by the way, in this time, can anyone tell anyone among you wants to be a surgeon? Just raise the hand. I can see Hassam Bhalli. Hassam, yes, we have today our yes, Dania. Sir, Dania is a final year medical student, and
Very nice.
she has been following me for some time.
Very
Assam
good.
is our colleague from anesthesia.
Very
And
nice.
sir, I think here we go. So you can start now.
Okay. Assalamu alaikum. Good evening to everyone who is right now with us on this platform. Let me introduce myself first. Who am I? I am Dr. Luqman Osman. I am a surgeon, and my specialty is upper gastrointestinal surgery, bariatric surgery, surgical oncology, and obviously general surgery at large. And I'm really grateful to Dr. Zishan Hashmi, who has been my friend, uh, brother, and we have been together, in so many surgical, procedures over many years. That we have a very fast friendship and a brotherhood, not only on the basis of the sharing of the profession that we have, but also because of the mutual interest that we have. That is about promoting, education, and promoting the idea that medical education is a lifelong learning process. That's the most important thing. That the medicine is a lifelong learning process, and once you have stepped into a surgical specialty or whatever, or any for that matter, any specialty of medicine, you just keep on, growing yourself. And the way to grow yourself is by, actively seeking knowledge and seeking good experience and good comradeship. That you need to have good friends and good colleagues from whom you can learn, with whom you can interact and benefit. And it's usually is a mutual benefit that we learn from each other, and we get better by sharing information, knowledge, experience, and that's how we all grow in this specialty of, for that matter, any specialty of medicine, whether it's surgery, medicine, anesthesia, radiology, ophthalmology, all of them. We have the same modus operandi, that we are once in a specialty, we have to keep on growing. We cannot stop the process of growth, because the world moves, and with it moves the concepts, the understanding of diseases, the treatment methodologies. They all change. And once they have changed, you cannot hold on to what was, you know, very dear to you, because you're very good at it. And you have to adopt the new methods, new methodologies, and new understandings as they come and as they are proven by the evidence-based practice. And you need to be scientific, you need to be methodical, systematic, and believe in a culture where you are a part of the system. It's not that you are yourself the person, the prime promoter, the protagonist. No, you are part of a team. And in that team, in the current methodology of medicine, everybody has an equal stake. Everybody contributes in the best manner possible for the care of the patient. And at the end, it is a win-win situation. It's a win-win situation for everyone. It's supposed to be like that. It's not like that one has to take the bulk of the credit. It's rather there is glory enough for all. There is for everyone something which a person can contribute and from which the patient can benefit. So I'm a surgeon, and we all know that surgery is basically um, it basically if you go to the etymology, the how the word has been constructed, it's basically came from Latin, and the word
Pardon,
was and this word is very now it's been adopted because obviously we know that the Latin languages of Europe, like the French and the Italians, they still use the word. Even the Germans use it, though the Germans are Teutonic. They are of a different race, but they still use the same root of the word chirurgy, which is handwork. So whenever you treat a disease by manipulating and by using your hands, that was known as surgery. This was in obviously it has to you have to contrast this idea with the idea of medicine, because medicine came not from Latin. It came from a word which was prior to Latin, and that was an Etruscan word. And Etruscan civilization was the civilization of the Italian peninsula, which was, if you have some idea of the map of Europe, the Italy is basically like a long leg stretching with its shoe into the Mediterranean Sea. And prior to the coming of the Romans, there was a civilization known as Etruscans, and they had a word. The word was medics. And obviously, we know that the professions, they also come only when there is a pace of civilization moving forward. When the civilization advances, so do the needs of professions. So there was a time, an earlier time, when there was no need for a separate profession of medicine and law. So at that time, medics was a person who used to give judgments not only on the matters of treatment, but also on the matters of pertaining to law. So that was the root of the word. And whenever you treat a patient by opinion, that is medics. And with that, we had the root of medicine. And now, as the time passed and the civilizations moved forward, there was a need to have a speciality, a kind of a subclassified group within the profession. And obviously, they were coming not from the they came not from the bulk of the profession, but they were rather sort of a lateral entry, and they were usually the people who were practicing, even now in our rural areas, the barbers. So the barbers were the first ones who were adopted or incorporated into the mainstream of medicine as the people who used to treat the diseases by their handwork, by incisions. And obviously, as we can understand, the earliest of the operations were either the drainage of abscesses or debridement, which is the debridement in our common word, but it's debridement in French, and amputations. And obviously, the pace of surgery, it only gained when in the later half of the 19th century, when the first general anesthesia, or sort of general anesthesia, was delivered, and that was the ether, and that ether was delivered. And there's an ether dome at the place where it was delivered, and that was in Harvard, and Harvard University, and Massachusetts General Hospital, and that's in America, the Northeast, the New England. And they have a place, rather, it's like a Mecca for people, for surgeons. They visit the place where the first anesthesia was delivered, because once the anesthesia was delivered, the gates of surgery were open, and then the pace of surgery uh, gained such a momentum that we have now come to a point that surgery has transformed into something different. So only with the coming of the anesthesia that we were able to um, provide a safe surgical practice. And obviously, once the gates of, and we all know this is Dr. Zishan's specialty, but anesthesia was the lever on which we lifted the bulk of surgery, the stone of surgery. We were able to lift on the lever of anesthesia. And once the anesthesia was there, the gates of surgery were open, and lots of surgeries became possible simply because the patient could be delivered a safe, pain-free passage during surgery. So that's how it was, and that's how it has remained. And obviously, specialties have evolved, and so has some anesthesia, and so has surgery. So from ether now, we have all the sophisticated stuff. From the first of the tooth extraction, which was the first surgical procedure done, to the latest robotic and minimally invasive that we are doing now, we have seen a huge transformation. And it has all happened in nearly 170 years. You don't have the surgical history running very deep. We have, as I said, there was a huge gap um, between that period and through the Middle Ages because there was no ample anesthesia. Surgery had to be fast, it had to be cruel, and only the large-hearted would be practicing it. So the surgery became a sophisticated job only once the anesthesia came. And then came Lister and Semmelweis, who changed the concept of this delivery of a safe practice, and they gave the concept of asepsis and antisepsis, that how to keep the wounds clean, and if they got infected, how to keep the infection, how to treat the infection. And surgery became a different world altogether. Once we knew how to give the patient a safe passage free of pain and surgery, and then we had the ability to save the wounds from infection, the surgical world was totally open, for the gates were open. You would be surprised that the first reporting of appendicitis because came only in the later part of the 19th century. So you can well imagine that there was no disease as acute appendicitis in the days of, let's say, for example, the 1850s and the 1860s. It was only towards the end of the 19th century and the early part of the 20th century that we came to know that there's a disease called acute appendicitis. You can very well imagine that how much the face of the surgery and the medicine had to change with these two advancements of anesthesia and asepsis and antisepsis. So surgery is an amazing field. It's a very interesting field, and those who venture into surgery, they usually have a kind of a disposition to go for anatomy. As I remember my days in medical school, that I was very much interested in anatomy, so much so that my professor of anatomy used to say that don't you have anything else to do than to sit in the dissection hall all the time and do the dissections, because I used to be busy dissecting and helping all the demonstrators that they were there in medicine and surgery, in anatomy, helping them prepare models, helping them sorting out all the stuff, and that's how it was. So so this is how, and but otherwise, the old concept that the surgery has to be for a person of force or somebody who can, it's like a heavy work. It's no longer heavy work. It's a very sophisticated work, or much of the work is done by the fingers, and we have sophisticated instruments. We have lots of new advances which have made the job of surgery easier and easier. Though obviously your intellectual input has to be stronger and stronger, but it doesn't mean for that matter, I will give you an example of orthopedics. In my days as a student, I remember that this orthopedics used to be a very heavy work, but it's no longer. I'm sure you must have been the students who are here. They must have been on rotations in various in their own respective medical institutions, and they must have seen that orthopedic is a very delicate now profession. Incisions are made, very nice hemostasis, which is a control of bleeding, is done. the way the bones are manipulated, the way the implants are placed, it's very sophisticated. Even how the joints are replaced, it's very sophisticated. How the scopes are passed into the joints to examine them inside, there's again a very sophisticated practice. So likewise, neurosurgery is no longer, a very invasive. There are people who are doing minimally invasive neurosurgery. They use scopes, and and obviously the work has been shared by other specialties, and there are lots of gray areas where we share the boundary of practice with our colleagues, like in radiology, interventional radiology, and so on and so forth. So that's how it is. But I would say that anybody can do it. Anybody can practice surgery, except that you need to be prepared, that long hours, dedication. But otherwise, there's no physical kind of encumbrance. Anybody can practice surgery, provided that he has the appetite for that. So much so, those children who are having autism, or those who are having the hyperactivity disorders, the Asperger's. Many of them now practicing surgery now. Recently, there was a news that one of the finest graduates this year, from the not this year, but a couple of, I think, the recent times, were in America. The American Board of Surgery was a patient, or was once a patient of autism, but he has done well in his residency, and he has come out as a surgeon. So, in my view, there's no encumbrance, but you need to believe that we are a team. We all have a stake in the management of the patient, and it's a collaborative effort. It's a multidisciplinary management, and we all do it for the benefit of the patient. We all have a stake, and we all play our role. And uh, if we go on to the areas of where there's a lot of opportunity in surgery, that is in the minimally invasive, whether it's urology, whether it's neurosurgery, whether it's my specialty, which is surgery, general surgery, and it's allied specialties like upper gastrointestinal, lower gastrointestinal, hepatobiliary, pancreatic, all of them, they have a lot of opportunity for robotic and minimally invasive. And well, you have to see what fits you, where you fit in the, and obviously the as it was in my case was a bit unique, because I was very much clear right from the outset that I will be following the track of surgery. But there are many students who cannot make up their mind, and I can empathize. You always remember that the word that you have to believe in is empathy. That you can feel what the other is feeling, though you may not support him, you may not agree with him, but you empathize. So I can empathize with lots of the junior colleagues and students, that they take some time to make up their mind, which is acceptable. But obviously, you need to remember the best time to join a specialty is right after the graduation, because the competition in getting the residencies is getting tougher and tougher and harder and harder. So one has to make up his or her mind accordingly. And uh, we need to remember that you have to believe in the Say's law. The Say's law is that good supply creates its own demand. So you must remember that you need to be good and the best. And once you are good and the best, you can, improve yourself. And once you move, you can, get better and better. And and obviously, the prospects of surgery, they are good everywhere. They are good inside the country. They are good outside the country. But you need to prepare yourself accordingly. You have to see where you fit, where you see your future is. And well, I am outside Pakistan, so I made a choice, and I'm outside. Many of my colleagues, they prefer to stay there, prosper, and they do prosper, and they do get better. But that's how it is. We make choices, and we follow that. But nonetheless, we need to believe that the path to success in any profession or any specialty is a lifelong learning, that you need to learn every day. something new, improve your practice, incorporate something new into your practice, which is evidence-based, be scientific, be very evidence-oriented, be able to understand research, be able to carry out the various studies whenever they are given to you, and be part of, again, it's a teamwork. You need to understand that you have to believe in teams, that no longer it's a solitary flight, it's always a team. We are together playing the game. It's not one person playing the game. It's no longer a, a individual sport. It's a team sport. So we help each other, we support each other, and we move forward. And we need to remember that we need to prepare ourselves for the future roles. You start off with your graduation, you do well, you go for your exams, you have lots of tracks. The tracks are inside Pakistan through the College of Physicians and Surgeons, outside Pakistan through the Royal College of Surgeons, and in America through the American College and the American Board of Surgery, and likewise in Australia, New Zealand. And there are many students who, if they prefer, they can learn a new language like French or German and move to France or Germany, or Sweden even. I have seen, because I have been practicing outside Pakistan for a number of years, I have seen Pakistani surgeons of Pakistani origin who went to Sweden. I know one such neurosurgeon. He left Pakistan to go to Sweden, and he became a neurosurgeon there. And I found surgeons from Pakistani origin in France, in Germany, though they are few, because the bulk of us, because our movement is always westward in the direction of the English speaking core, whether it's Britain or whether it's the Ireland, whether it's United States of America or Canada. Um, and also, some of us, go towards the south, that is the across the equator into Australia and New Zealand. So all of these institutions, the countries have their separate institutions, they have requirements. But remember, once you're moving towards the English speaking world, you need to rely to get yourself registered either through the IELTS or OET. You must be very well aware of it. You need to get the good scores in that. And once you have got the good scores and you're prepared well, you can give the primary exams, and you can, start thinking about getting a professional, job there. Obviously, residencies are a must to achieve and attain professional standing. In Britain, we have the Certificate of Completion of Training, which is known as CCT, or its equivalent, which is CSER, which is basically an equivalent if you have been trained outside Pakistan, outside Britain or Ireland, but you were having a proper logbook or a proper training, so you can get a equivalency, and you can be, you know, get yourself, recognized as a surgeon. So that's how it is. In America, we all know it has to be steps. And once you do the steps, you have to look for the matching, and you're matched. Once you're matched, you're taken up as a first year resident. First year residency is not a confirmation of residency. First year residency means an entrance into the specialty. If you do well in first year, you complete your residency. But if you don't do, they give you a chance, and you have to repeat the first year. But ultimately, it takes about 4 or 5 years, followed by fellowship, and then you start your practice in your specialty. Likewise in Germany, similar method. Likewise in France, it's all similar. Even in Spain, it's all similar. Because I'm in the Middle East and I've worked in Britain, in the Middle East, we have lots of people who go to the France and Germany and Spain. They have a similar, except that you need to have a good grasp of the knowledge. They have a certain criteria, a certain level of proficiency of language, and then you have to pass the just like an entrance exam, like a PLAB or like an MRCS or equivalent exam, and then you are taken up and you start doing your surgical training. And but you remember that you need to keep on preparing yourself by getting your resume, and you have to, resume is your curriculum vitae. It has to be a robust one, and you need to know how to really cultivate a resume. You need to get better, better, and improve yourself. And I see somebody has written down that they are doing part 2 in surgery. That's wonderful. That's a really wonderful track. Do your fellowship in surgery and then think about improving yourself further or in any subspecialty that you might choose, like upper gastrointestinal, lower gastrointestinal, or hepatobiliary, pancreatic, bariatric, and surgical oncology. All of these are very valid specialties, and you can move in that. Likewise, those who are working in urology, they can look for subspecialties of urology, like andrology, which is male infertility, oncology, urological oncology, reconstructive oncology, urology. So there are many specialties. Likewise, even plastic surgery has lots of subspecialties, like vascular surgery has lots of, it's not only now open, you have interventional, and there are surgeons who first do general surgery, move into vascular fellowships, and then they do a second fellowship on interventional, and then they become minimally invasive interventional vascular surgeons. So obviously, it's a long track, but it comes down to your dedication. It comes down to your focus. It comes down to your circumstances, and what are you prepared to balance in your life? What are your priorities? What's coming your way, and how you are going to move forward. If you have a good mentor who can guide you, that's an excellent thing. A mentor is the one who treats you like a family member, who takes you along, and he treats you like a son or a daughter. And his main aim is prosperity, your prosperity in your profession, that he wants you to move forward. Whether you are a or male or female, it doesn't matter. All have a valid stake in the profession, and all are supposed to move forward. And I missed one specialty. The breast and the endocrine is also a standalone specialty, and you can move into that as well. Breast is amazing for females. Endocrine is also amazing. Lots of minimally invasive procedures are on now, in thyroid, adrenals, and even pituitary. And so it's the common frontier for neurosurgeons and endocrine surgeons. And lots of surgeons are, moving in that track of endocrine. So keep on exploring your opportunities. Um, we are there to answer any queries that you might have, any direction that you might need. And the only thing is, as I say, that you need to believe that once you have joined medicine, it's a lifelong learning process. It's an ever-changing field of practice. It keeps on changing and keeps on improving. New treatments will come up, new understandings will come up. Do not hang on to the old one. Keep on moving forward and improve your practice for the betterment of the patient. Uh, Always think about the patient first, his safety, and delivering the best possible care to your patient. And and the best way to treat a patient is as if the patient is your own, a family member. And that's the benchmark, that you always treat a patient as your own. Once you start treating the patient as your own, um, you will do fabulously well. And I wish you best of luck. Thank you very much.
Thank you very much, sir. I'm sorry. Anyone of you wants to ask
Yeah,
any
and
question?
yeah, absolutely. I would like to have any question. They
And
can ask me any question right now.
yes, because I will just add on to the what sir was saying, that actually surgical specialties have not been totally disintegrated. Okay, in Pakistan, actually, general surgeons are doing everything, but internationally, it's going on in Pakistan as well, but of
Yeah, yeah,
course on a slower pace. But it will catch maybe by the time you
yeah.
people.
It's international. It's an international movement, and Pakistan will come onto the. We will do the same. Obviously, we have to see our issues, our problems, our you know uh, scenarios. So that's how it is. But you have to see which market that you're preparing yourself for. Is it a local market or the international market?
Sir,
So,
some one question
so
from my
there
side.
is a, Rishan, I'm just interrupting. I'd like
Mhm.
to do an yeah, wonderful. So there is Osman. He has done FCPS general surgery, preparing for MRCS. Wonderful. Go for it. You can do it. It's a pretty easy exam. The books are there, and just mug them up. And once you have done FCPS general surgery, that's perfect. And you have asked me, how is this route? It's a very good route, Usman. Do it. Do it. And that's all I did as well. I was an FCPS first, and then I moved towards MRCS and then double FRCS and then European boards and fellowships. So that's how it is. So you have taken the right first step. You are prepared well for your life. So move on. Let's do it. Do it.
Yeah, sir,
And
actually, one question I'm asking on behalf of this is a question which is in my hand. And there are some people who
yes.
have tremors in their hands, number one, or some people
Mm,
who have some physical limitation that they are not able to stay in one position for a long time. So what's your opinion? What they
Well,
can
well,
do?
well, Dishan, I've never disappointed anybody. Tremors, you will never be able to judge yourself right now. Once you, what I tell you, it's all about hand-eye coordination. Once you are in the profession, those lots of people, lots of students who tend to have tremors, those tremors get washed away. These are just essential tremors. The tremors, they are not pathological tremors of some, may God forbid, anybody to have the pathological tremors. These tremors are essential tremors. They can be, controlled, and I wouldn't, but it's up to you. If somebody has a tremor, is bothered by it, doesn't want to do surgery, it's up to him. It's up to him or her. But as an impediment, I would say tremor is certainly not a impediment. Well, Palmer hyperhidrosis. No, no, not at all. There's a lot of treatment for Palmer hyperhidrosis. Now you can get your, cervical sympathectomy is done, minimal invasive. There are lots of other methodologies as well. So hyperhidrosis is no longer, there are lots of sprays. Don't think about hyperhidrosis as a major reason of not adopting surgery. So that's not a contraindication. Look, remember, there is a very fine poem, and I have been reciting this poem to myself, and that is, uh, uh, it starts like that. My mind to me a kingdom is. So it's my mind which decides what I want to become. Okay, my mind to me a kingdom is. So if I am having an idea that I want to pursue this track, and I feel that it is possible and feasible materially, spiritually, and given the circumstances. So I should follow that path. And whether it's hyperhidrosis, tremors, everything is manageable. One of the very famous surgeons I
Uh,
know is a polio stricken. He has one of his he has one of his limbs for polio. And there was a resident in my time under when I was assistant professor in King Edward Medical University. She was also having polio, but that didn't deter her from pursuing surgery. She moved on. She did surgery, and God bless her for that. So polio-stricken people have seen becoming surgeons. So it's okay. Nothing. Paralympics that recently concluded in Paris, and so on, for so many years happening. It proves people with physical limitations can do anything. It's just your mind what decides what you want to do. It's your mind. Okay, so we are overburdened and some toxic environment. Yeah, remember, toxicity of surgical environment is international. Remember what I said. Toxicity of a surgical environment is an international phenomenon. You will face it. You have to live it. You cannot shy away from it. You need to find methods, and there are many methods, and you need to devise your own method how to cope with it. But that's how it is. Surgery is highly competitive. It's the best are competing against each other. So there will be a lot of blood, but that's how it is. But you need to not shy away from it. Be very cordial, be very courteous, improve yourself, show your interest, try to be very methodical, systematic, evidence based, very cooperative, and very, very, astute. in your behavior, in your methodology, in your note keeping, writing. Show that you are made of higher stuff, and people will give you way. They will give you space, but you need to show that you are interested. It's not that you are trying to be evasive, because once you're evasive, people will not give you space. You need to be very, very positive about yourself. You have to have faith in your in intrinsic faith in yourself. Once you have that faith, you can do it, and it's doable. It's a doable job. I would never say so. Yeah, Dani is asking, how is his career choice women? It's a wonderful choice for a career. When girls can become brilliant gynecologists, they can be brilliant surgeons. That's it. That's the end of it. And they can, this is what I see. I remember, and my dearest, my wife, she's a gynecologist. So, I see her, doing the most, the heavy hours, the most of the procedures. So, surgery as a choice is a career choice, no longer a debate. Ladies can do anything. They are at par or even better than men. Take my word, they're better than men. So, any further questions?
Wrote, I have just written the same comment in a different way a little
Yeah,
bit.
yeah, yeah.
Yeah, of
Yeah,
course,
you
because
just have to be. Remember, you have to be mentally robust. Your robustness is very important. If you're robust yourself intrinsically and you prepare yourself for the task, you will do it. That's it. Don't shy away from it. Well, you have to be patient. You have to be patient. If you want to go to Britain and America, it's a doable job. It's a doable job. Wonderful cardiovascular surgery. Wonderful, wonderful cardiovascular surgery. Everything is wonderful. Alia is asking about research work. Yeah. Now, this is something that you need to be conscious about, that you need to build up a curriculum vitae, a CV or resume, and you need to be a part of studies, whether they are case reports or some retrospective series. But write something. Get on that bandwagon of writing early and start with simple stuff. Don't go for the bigger stuff. Write simple stuff, get it published. There are lots of venues now. The world is open. Lots of journals are open access. They accept people. They want new authors. And the younger you come into their eyes, the better it is. Remember, the earlier that you step forward, the earlier you already have an advantage. It's like a sprint. It's like a marathon. Once you have your step forward and you are taken the shoot, you are ahead, and you just need to maintain your momentum. Start with something simple. Start with something easy. Always look for easy ways, and don't try to. And then obviously, once you have done the easy work, you will find that there are people who are trying to bring you up, and yeah. But
like,
there is, yeah, absolutely. Zishan is absolutely right. There are lots of ways of entering into the American system. After your FCPS, you can do your steps and go up and get you matched for fellowship. There's a fellowship council, and you can do it. There are lots of ways. Once you're committed, lots of ways, lots of ways.
actually, back in Pakistan, we don't have this information about any specialty. That there are
Yeah,
people
yeah.
who just ruled it out that oh, it's very difficult to enter in anesthesia. It's very difficult to enter in surgery
Mm.
in US. The thing is that
No,
this
no, not at
fellowship
all, not
pathway
at
is
all.
open for anyone, anytime.
Absolutely,
And
it's
actually, they
open
would
for everyone.
prefer the people who have some
Yeah,
background
yeah.
experience in the form of
Absolutely.
both qualifications as well
God
as
bless you for that, really.
practical
Absolutely.
experience. So
Absolutely. Absolutely.
so
You
actually,
know,
for that
I,
thing,
yeah,
yeah,
yeah.
you just need to have some like you just first of all you need to finish the USMLE. You have to
Yeah,
break these
USML you need is pivotal. Yes, pivotal.
butterflies about USMLE. People think as if it's something horror movie or horror story. It's
Yeah,
not
yeah,
like
yeah.
that.
It isn't.
And
It isn't. It isn't. It's all methodical. It's all about, your interest. If you are interested, you can do it. You can finish your FCPS, do your steps, look for the chosen specialty, fellowships, and go there. They will take you up. They will never say, if you match the criteria, they will take you up with open arms. That's it. They will accept you. That's for sure. That's for absolute sure.
And actually, I will tell you something, because people just think that UK is very easy or Ireland is very easy. But thing is that everything is
Mariam, you can do that as well. Yeah,
yeah,
you
yes.
can. Mariam,
I'm just telling you that actually everything is with relationship to the population over there. US has population of around 350 millions, okay, and
yeah,
it
yeah,
is a
we're a big country,
big,
big
big,
country,
big market, okay, and they
big.
are welcoming the foreign graduates. Yes,
Yeah,
maybe it's not like that you will have green carpet reception, but if you are
welcome.
good, they will
Um,
not stop you. This is for sure.
Absolutely, absolutely. They love talent. They love talent. They love to nurture talent. They love to incorporate people, the best people into their system, and they love it. They're very positive people. They're very positive.
Dr. Lukman, how was your experience in Korea?
Wonderful. It was wonderful.
Luckily, he was not in North
Sir, I
Korea;
am
he was
Dr.
in South
Ahil
Korea.
Ahmed. I am consultant ENT. So, first of all, I want to welcome you back to Saudi Arabia after this fellowship.
Ah,
Uh,
Raheel, how are you, Raheel? Good to hear from you. Oh
I
my
am
God.
fine, sir.
Wonderful. Oh, wonderful. I saw Raheel
Yeah,
and I was thinking,
long time.
oh my God. But I was not sure, but yeah, good to hear from you, Raheel. But Raheel, it's good to
Sir,
hear. How are you?
yeah.
How's everything?
Sir, everything is fine, and I'll meet
It's
you
good,
soon.
good. Yeah,
But
Korea is a
about
very good experience. It's a very
yeah,
good opportunity to do fellowships there, and you
okay,
get matched similar way. You have to send your papers. They call at these. There is a certain time that you have to push your papers, and once your papers are pushed, there are obviously limited seats there. But obviously, you have
okay.
to compete, and you once you're accepted, you're on. That's it. You go there, and there's a hands-on job, and you will find the cutting edge technology. South Korea is one of the leading economic powers of the world right now. One of the leading economic powers of the world. Their economy is booming, and they have major centers of excellence. So wonderful! It's a wonderful opportunity, and
Is there any
you would
language
enjoy
issue,
it.
language barrier, sir?
No, no. I tell you, language barrier as far as the training is concerned, no. But obviously, patience, yes. But how much patient interaction do you need beyond because your all the electronic medical record system is all in English everywhere internationally. So
Okay.
even they record their data in English language. There are all their proceedings in English language. So you are not losing anything. You are a part of the system, and you have an equal access to their patient data as long as you are their fellow, and you keep on following your patients and seeing their TPRs, their daily labs, and how they're proceeding, their pathological reports, and how their follow-up is being done, and how the treatment is being planned. Everything is in English. You will enjoy it. Surely you will enjoy it.
Any any
That's great.
other any other questions? Yeah, actually, Mariam, I would like to answer this question. Mariam Tanveer, actually, after MBBS, because there was a growing trend before many years ago that the people who just graduated, they don't do the house job and they straight away go for USMLE steps. Yes, maybe 10 years ago when maybe the competition was not as much as of today. So it's always nice to have a backup plan. You all of you should do whenever you are doing USMLE, you should do a backup FCPS and start doing your training so that you don't lose your time. Okay. And if you are not able to catch the match in the first go, you can finish your fellowship and then you can go enter US through fellowship pathway. Okay.
Yeah, but yeah. So there are so many ways of entering the American system, and not to lose hope. Keep on working hard, and try to focus yourself on the goal that you have, and you will find ways, and opportunities will come your way. And as long as Dr. Zishan is there, you have a portal where you can ask questions, and if these questions are passed to us relevant to my specialty, I'm very happy to share all the information and all the knowledge.
Yes.
And wish you all of you best of luck. It's all possible. It's a doable job.
Sir, this was a
It's
question
wonderful.
by
It's, yeah,
MRCS.
MRC is a wonderful career. It's a wonderful career pathway. It's wonderful. But you need to follow the, you can't be a general, not in the generality of oncology. You need to follow a certain subspecialty. And in that subspecialty, you have to follow the oncology pathway. That's how it is in Britain. But in America, it's different. In America, surgical oncology is a standalone specialty. So there's a fellowship dedicated to surgical oncology. So that is basically for complex surgical issues. So they have a surgical oncology specialty. But as far as Britain is concerned, Britain has already divided the general surgery into various specialties, and within the specialty, there are tracks of oncology. So, like for example, I am a visceral oncologist. My oncology starts from the diaphragm to the pelvis, excluding the female pelvic organs, but obviously the lymph nodes, the colon, the liver, it's all the part of my specialty. But obviously, I am a dedicated upper GI. But considering that I have a training in visceral oncology, I have an understanding of how things are, and the qualification always helps you. Okay. So, Vishan,
Eyes,
can we?
yes, yes, we will just finish. So
Thank you.
it is said that eyes cannot see what mind does not know. So you will
Yeah,
not be able to
absolutely.
see, so you should have knowledge. Because sometimes
Wonderful.
you need to have the knowledge to do the to do something. Am I right?
Yeah,
What are you going to
gastroenterology is a
say?
wonderful specialty. It's a wonderful specialty. Remember one thing, that now everything is in gray area. So there are lots of common boundaries. There are lots of procedures are being taken away uh, from surgical hands to the gastroenterology. Gastroenterology is becoming very effective now. So you have lots of procedures which you can do, right from the bile duct stones to pancreatic duct strictures and stones and tumors and stents and whatnot. So the sky is the limit. Sky is the limit. I tell you, recently in my hospital we had a young female. She was a 45-year-old female with a family history of colon cancer, and surprisingly, her father had colon cancer as well. But this lady came, young lady. She was in her 40s, so a married female, and she had some sort of a bowel disturbance going on for some time, neglected, and she didn't focus on it. And then she had bowel obstruction. So guess what? What did we do? We didn't do for her any surgery. We just referred her to our colleagues in radiology, and they did interventional. They passed a stent. They passed a stent in liaison with the gastroenterologist. That's it. Together, the gastroenterologist and the intervention radiologist, they did together, and they passed a stent. No need for surgery. Now she can safely have chemotherapy, and she can have one-stop surgery. That no longer she has to have one surgery, then another. Rather, it is a stent, chemotherapy, and then surgery. So that's wonderful. That's wonderful. She will have a curative procedure now, because now she is on the chemotherapy. Once the chemotherapy is done, she can have her surgery, and once the surgery is done, followed up with another few cycles of chemotherapy and given a clean sheet of health. So that's how the surgical arena has changed now. So just it's not about a long time, just about just short while, a few years back, it was so that if you had a patient with large bowel obstruction, the answer was a surgical maneuver. But now the stents have come up, and stents are getting effective. I remember the debate was at the rectosigmoid junction whether the stent, whether beyond the rectosigmoid junction, whether the lesion is doable or not, because it's lots of curves, lots of loops, and it's not easy. But left-sided obstruction, stent pass, because the technology is getting better and better. Things are getting better and better. So the specialty will the treatments will keep on changing their shape. We are all for the patient. Our main aim is the patient. We have to deliver the best possible care to the patient, and we are working as a team. There's no loser in this. It's a win-win situation for everyone. The patient gets
As
the best possible care. The
Sir,
patient gets the best possible care.
did you see, or did you see anything with reference to this natural orifice laparoscopic surgery?
Yeah, we have obviously in upper GI surgery. I've been doing myself. So we do transgastric gists. So that becomes a sort of a kind of a maneuver. It's basically, it's not natural orifice exactly, but what we do is we do not go into the abdomen, but we just simply go through the stomach, take out the tumor, and stitch it up, and that's it. It's a minimally invasive procedure. But notes itself is either through the stomach or through the vagina. That's how it's supposed to be, natural orifice, but it has you know, a few centers are doing it. It's a doable job. It's a doable
Sir,
job.
one more
It can be
relevant
done.
question with reference to your experience in robotics. If you just see the cost
Yeah, yeah.
effectiveness, of course, robotic
It's
surgery will be
wonderful. It's
very
cost effective.
meticulous.
Studies have been done. Yeah, it's cost effective. It's cost effective, but it has to be. It's not cost effective on one procedure. The cost effectiveness comes after doing
Un-
some amount of
100.
procedure. Then, when you analyze it in economic perspective, you will find that you have done it becomes, you know, a balance. So obviously, it's a big debate, but it's a technology of which time has come. It's going to stay and it's going to prosper. And in my view, the future is not far when the robotic will totally displace the laparoscopic. It's coming now. It will happen. It is going to
because
happen, and
because
it's my
at
faith
least
it will happen.
even I can say for sure that in my like 20 years experience after graduation, I have in my eyes seen that people who were running away from laparoscopic surgery, now laparoscopic surgery is the standard of the care. Nobody does any surgery. Majority of the surgery, I
Yes,
think,
standard of care. Absolutely, standard
open
of care.
surgery
Pure
is
standard
now.
of care.
Yes, open surgery they are doing it, not doing for any procedure. Even
No
the
longer, no
patients,
longer, no longer,
the patients who
no
are
longer,
having
no
some,
longer,
yeah,
no longer.
anesthetic problem with reference
Yeah,
to
yeah.
laparoscopy itself, even then if they just see risk versus benefit, even then laparoscopic surgery is less invasive and less troublesome for those patients. Okay, sir, I'm really thankful for your time, and hopefully we will catch you more often now with more of academic discussion rather than career oriented discussion. So
Less
all
invasive,
I thanks
less
all of the
troublesome.
medical students,
Absolutely.
all of the people who have joined. Remember one thing, struggle, commitment,
Thank you very much. Very kind
and
of you for invitation.
hard work is important for any specialty. Okay, and of course because surgery has a longer
Absolutely.
learning curve. Okay, like if I compare it with other specialties, maybe
There's a learning
learning
curve.
curve is
Absolutely right.
relatively shorter. Okay,
Absolutely.
like in anesthetist, when we start
Yeah,
anesthesia
yeah,
after few days, spinal, endotracheal intubation, epidural, maybe the learning curve is short, looks shorter. Yes, again I use the word that eyes
yeah.
cannot see, but mind does not know. So the knowledge is the key.
Oh,
And
absolutely.
no, like
Knowledge is
when
key.
I 20 years ago, when I was just thinking about how I was, and I used to do anesthesia, and I worked very hard. And Dr. Lukman, I'm just not praising in front of him, but actually, usually there is a relationship like a mother-in-law and daughter-in-law between surgeon and anesthetist. Okay, but openly I tell you something that the commitment and what you say, that hard work which I have seen from Dr. Lukman, very few of the surgeons actually I have seen. Okay, so
Good. Very kind
because
words of you. Very kind words. Very kind
people
words.
just
I'm
say
grateful.
people
But I
just
think the
say
same,
that
this feeling is
surgery is a
mutual,
skill.
Zishan. You're also very hardworking. You're very absolutely
Surgery is a
hardworking.
skill. Surgery is a skill, but I think, in my opinion, a skill comes after the knowledge. Okay, so
Yeah,
thank
yeah,
you, and we will.
absolutely.
I think we should stop here. We
Thank you.
and
Thank you very much. Very
any
kind
of the
of you.
question which is left, all of you are welcome to
Yeah, yeah, yeah.
contact
Absolutely.
anytime. Okay, bye bye.
Absolutely. Thank you. Thank you very much. Very kind of you. Bye bye.